is here that we need to move forward with our meeting. I just want to say good morning. I'd like to welcome everyone that's in attendance here today and thank our committee members and witnesses for being here to discuss what I believe is going to be one of the most consequential issues that we will tackle in this upcoming legislative session. Today represents many firsts. This is the first meeting where I will preside over the House Insurance Committee as chairman. And to my knowledge, this is the first time that we've had a joint committee meeting between the House Special Committee on Access to Quality Health Care and the House Insurance Committee. Nothing like easing into the job. Do we have any senators here today? We don't need them. Just wanted to recognize any of those that might be with us. Convening this meeting so close to session when we will all be here anyway is not something that was done lightly. It's being convened because we believe it's necessary. This meeting has been called to explore the impact pharmacy benefit managers and Medicaid care management organizational practices are having on Georgia's patients, prescription drug prices, and community pharmacies and Georgia taxpayers. We have several speakers lined up today, and we're going to get to them as soon as possible. They have a lot of information that is relevant and pertinent to the issues that we're going to be discussing today. But I think it's important to point out that Georgia is not starting at square one when it comes to protecting Georgians from some of these harmful practices. So to that end, I'm going to ask Chairman Hatchett to share with us some of the good work that's already been done surrounding this issue by the state legislature. Chairman Hatchett.
Thank you, Chairman Lumsden. Good morning. You're right, Chairman. Good work's been done on all these issues. Just this past year, I'm proud to point out that the General Assembly passed landmark legislation geared toward the most repugnant of PBM and PBM-owned pharmacy practices, that of self-dealing via steering patients to pharmacies that are owned or affiliated with PBMs or insurers. This legislation, introduced by Representative Knight and co-sponsored by over 90 House members, was the first of its kind in the nation and received near unanimous support from both the House and the Senate. Chairlady Cooper also passed legislation addressing the practice of step therapy requirements this past year, which will help patients get and stay on needed medication fast. Prior to that was the Pharmacy Patient Protection Act, which was introduced and passed by Representative Knight and Senator Mullis in 2017 and updated in 2019. When first introduced, this legislation was again a first of its kind and went on to serve as a national model looking to rein in PBM practices such as mandatory mail order, charging patients copays which exceed the cost of the drug, and gag clauses preventing pharmacies from informing patients about cheaper drug alternatives. President Trump signed similar gag clause legislation into law at the federal level in 2018. I'm proud of this General Assembly for the nation-leading work that has already been done, but there's more work to do. For all the good work that's been done, many of the PBMs themselves have proceeded to ignore and make every effort to find loopholes in our laws, while at the same time, other practices harmful to patients continue to grow and spread across the prescription drug landscape. Also, while much has been done, something we've not done enough of is to publicly shine a light on these practices. At the same time, we're trying to stop them. That changes today. They say that sunlight is the best disinfectant, and that's what today is all about, shining a light on harmful practices that raise prescription drug prices, hurt patients, providers, and taxpayers. So you're going to hear about these practices from Chairman Knight, patients, physicians, and community pharmacists who are fed up with what PBMs and CMOs have done to the healthcare system and who've agreed to share their experiences with us today. Mr. Chairman, I'm ready to get started.
Thank you, Chairman Hatchett, for those comments. We have, as I've said, we have a number of speakers lined up today to share their experiences. First up, Chairman Knight, who is spearheading this. If you would please come to the podium and share your comments with us, please.
Thank you, Mr. Chairman, members of the committee. Thank you all for being here today. Our nation and our state have been arguing for the past few years over a governmental takeover of health care. It's been one of the most contentious arguments of the last decade, and it was an important conversation. But that's not why we're here today. I believe we've missed the larger, more important issue. That is a corporate takeover of our nation's health care. In short, hundreds of millions of Georgians' health care dollars and a massive share of our health care decisions are taken from us. Wall Street is bleeding us of money and choices, and we're going to take both of those back. What kind of decisions? Patient choice of pharmacy. We've done some work on that in the past, but the PBMs and managed care companies haven't been discouraged from the practice. They're obscuring the price of prescription drugs with complicated methodologies. They're forcing patients to more expensive brand name drugs and refusing coverage of cheaper generics to pad the profits of PBMs and CMO via rebates. And they're reimbursing PBM and CMO affiliated pharmacies more than competitor pharmacies and retail independents. And so in light of these practices, I suppose it shouldn't be shocking that CVS, one of the biggest PBMs, is sitting on about $6.5 billion in cash, while they paid out $2 billion in dividends to shareholders in 2018. Anthem, which owns Blue Cross Blue Shield, is sitting on $22 billion in cash and paid out $776 million in dividends to shareholders in 2018. Now, Blue Cross happens to have a presence in Georgia, as we all know, including a Medicaid care management organization known as AMGP, which many of you know as Amerigroup. So does Centene via their Georgia CMO known as Peach State. Centene also happens to own their own PBM called Involve Pharmacy Solutions and their own pharmacy called Acaria. I'm going to put up a graph of stock market performance. As you can see, the managed care profits have soared beyond the stock market and beyond any comparable size economic sector or index. Now, I'm a conservative, and I like it when people are making a profit. But I'm also a legislator trying to keep quality health care affordable in my state, and to keep outside groups from sending what my constituents pay for health care off to some gilded salon in Manhattan. The Medicaid managed care organizations were paid approximately $4.29 billion in 2018 by the state of Georgia. And that's where the fun begins, with over $500 million for administrative services, with the bulk of that going to affiliated companies. $170 million going to a net gain, and another $140 million being paid out in dividends to the Wall Street parent companies. And then we get to the prescription specifically, and the feeding frenzy wraps up more with $50 million difference in 18 between what the CMOs paid the PBMs for their drugs and what pharmacies were paid. Profitable drugs being steered to the CMOs and the PBM pharmacies with unimaginable markups. In one example, we were able to uncover an independent pharmacist was reimbursed $34.50 per pill for a drug that was used to treat leukemia. It's called imatinib, forgive my pronunciation, in a Medicaid fee-for-service, while a CMO reimbursed an affiliate pharmacy about $279 per pill. Again, look at the difference, $34.50 to $279. The CMO paid its affiliates 708% more per pill than the independent pharmacist was paid. Another CMO reimbursed a pharmacy affiliated with its pharmacy benefit manager about $302.50 per pill. That's about a 776% markup per pill. In another example, an oncology pharmacy was reimbursed by Medicaid fee-for-service $4.39 for a drug to treat cancer called capecitabine, excuse the pronunciation, while the CMO reimbursed an affiliate pharmacy $27.63 per pill. The managed care organization paid its affiliate 529% more per pill than the oncology pharmacy was paid. All of this money, and it is a lot, is being taken by Wall Street year after year. But it's more than that. It's people and its patients' care being undermined and compromised. The power to make healthcare decisions is being taken away from patients, families, doctors, pharmacists, and dentists in our communities. And that's what truly rankles me. Today you're going to hear from patients, including a cancer patient, and her almost daily struggles to get the medications she needs from her BPM mandated pharmacy. You're also going to hear from a woman who's been using the same independent pharmacy for almost her entire adult life and is now being told that she must use CVS. And you're going to hear from a mother who's willing to do anything to get her son the medication that he needs. You're also going to hear from an oncologist who I'm sure would rather be treating her patients today, but who has taken the time to be here to fight for her patients' access to care. You'll also hear from the dean of Mercer Medical School regarding how PBMs have hurt Georgia's healthcare system. You'll hear from several community pharmacists who are here to share examples of how the PBMs and the CMO practices hurt patient care while at the same time compromising their very existence. The unifying theme that you'll hear throughout today's testimony is that patients and providers are being harmed by huge corporate interest that put their profitability above the lives of Georgians. We're not starting from the beginning, as Chairman Hatchett has duly noted, but the games haven't stopped, and some of the PBM and their affiliated pharmacies continue to steer on a massive scale, even though the new law took effect just last week. This is what steering looks like. A letter. If you look at it, starting January 1, 2020, you'll need to fill your prescriptions for these medications at CVS Pharmacy or through the Caremark mail. If you fill them anywhere else or in a 30-day supply, they will no longer be covered, and you'll pay 100% of the cost. Did they not see what we passed last year? I'm so thankful that Mrs. Arrington is here today, and she's her willing to stand up for her choice and the choice of others. You know, we've done great work, but this year we're going to finish the drill. And we're going to do that by, one, bringing true transparency to prescription drug market, while at the same time closing the loopholes in existing laws that managed care organizations, PBMs, and even the state contracted PBMs use to continue to engage in practices that are harmful to patients. We're going to seek a carve-out of prescription drug benefits from Medicaid managed care. West Virginia did this, and in 2018, an actuarial study showed that the carve-out saved over $50 million, while at the same time paying community pharmacies fairly. And lastly, we're going to bring true oversight to the PBMs and care-managed organizations that contract and subcontract with the state. We, the members of this General Assembly, are tasked with appropriating funds, yet we're doing that in the darkness. We don't have access to the contracts or to the payment structures, and I can tell you that I asked for these contracts back in October via an open records request, and I've yet to receive one page of the contracts. I've had no objections to that request. There were no pages that were sent to me, even pages that were redacted. They just flat out haven't produced them. Up until now, it's been the fox guarding the hen house, people. And these companies have backed up a Brinks truck, loaded it up with Georgia money, and driven straight to Wall Street. All the while leaving Georgia patients, healthcare providers, and taxpayers to clean up the mess. It is time to take our health care back. I appreciate your attendance today, and I hope you'll pay careful attention to those witnesses who have come forth today to give their testimony. Thank you so much for your time.
Thank you, Chairman Knight. As mentioned, we have a number of presenters, and some of them are on a tight time schedule. I want to call Dr. Melissa Dillman. I believe Dr. Dillman is an oncologist from Rome, Georgia, where I'm from, and she has had some experiences that need to be shared. And if you would please come to the podium, and we look forward to hearing from you.
Thank you very much. I just sent a tweet out this morning that I was excited to be here, and only in Georgia can you hit a deer and still make it to Capitol Hill from Rome. We'll see about the car later. So good morning, and thank you, congressmen and women, for being here this morning, and for all those who've come to share their stories. As said, I am a medical oncologist practicing in Rome, Georgia at the Harbin Clinic, and I take care of patients in Northwest Georgia. We see everything. I'm a general oncologist, so I see everything except for pediatrics. And I want to come here today and congratulate you on attacking a very critical issue in healthcare and the important steps that you made last year in passing that key legislation. But I think transparency is key, and bringing a spotlight on this issue is very important. It's been something I've been doing at the state as well as the national level, and going to DC and talking with our U.S. representatives and senators about this same issue. So I take care of patients every day who every day is precious to them, and every minute that they don't get their medication is critically important in their battle to fight their cancer. Currently, many of the drugs that we use, and more than 50% of the drugs that are in the drug pipeline, are oral medications. These medications are often targeted, therefore less toxic and more active in patients' critical fight against their cancer. And so these are becoming increasingly part of our practice. So over the last 10 years, we as oncologists and oncology care providers who already are giving IV medications have really used those same skill sets to deliver these oral medications to our patients, monitor toxicity, adjust doses, hold doses, just like you would with an intravenous medication. About 3 to 5 years ago, my ability to give those drugs to my patient the same day I prescribed them or the same day I changed the dose was dramatically changed. I remember the first day I was told by one of my nurses, we can't fill that here anymore. And I said, why? It's sitting over there on the shelf. And they said, well, we're being told that they have to get it through a mail order pharmacy, something I had never even heard of before. So I want to say that this has led to significant stress within my practice. I've had to employ 2 full-time employees that their entire job is just to get my medications for my patients. But more importantly, it's become a stress for my patients, and that's what I'm here to do today, is to make sure that my patients receive the care that they need. So I wanted to tell a few stories. Several of my patients couldn't be here. One of my patients has passed away, but I think that their stories are vital and will stick in your minds, and it's what sticks in my heart every day and what makes me come down here and hit a deer on the way here to talk to you today. The first person I want to talk with you about was John. He was a glioblastoma patient, so he had brain cancer. He had recently retired. He was an insurance salesman, but his passion in life was sailing, and we do have a sailing club on Weiss Lake up in northwest Georgia/Alabama, and so that was his passion. And one of his friends, when he found out he had brain cancer, said, I can take you on the sailing trip of a lifetime. We're going to take a boat from Catalina to Panama, and I want you on it. So John waited, and he planned, and he got through with his radiation. Usually after this, we give a drug, a pill by mouth, and it starts off at 1 dose, and then next month you get to the next dose. So he had it all planned out. He even had these electrodes that he was wearing on his head, and he found the perfect sailing cap to go over it. He was ready to go, had his plane flight booked, and he was not able to fill his medicines in our office. But we had already sent in the appropriate dose 3 weeks ahead of time, so it'd make sure it'd be there on time, and they sent the wrong dose. He didn't have enough of the medication to make it out to Catalina. He didn't make his flight. His friends bought him another plane ticket, and he made part of the trip to see the sailboat came in. But he passed away about 6 months ago, and I always think about John and how he never got to take that sailing trip. And that was heartbreaking, because I had that medicine in my pharmacy and could have given it to him, but I wasn't allowed to, and he missed his sailing trip. This morning, I was talking with one of my oral chemotherapy nurses on the way down here, and she was sharing with me about another one of our patients. Sharon is a 52-year-old woman still working for the state, and she has rectal cancer. So for rectal cancer, Representative Knight, you did a good job. It's capecitabine, or that's how a Southerner says it. That drug that he put up there earlier, that was $4, I'm sure is what we got. We would have gotten reimbursed, but $27 to the PBM own pharmacy. She was on that during her radiation, and then you get started after that. I'm sorry, she was on it as a pill by mouth, and then she was going to get it with her radiation. So it's a lot of work when you try to get radiation scheduled, and this was the holidays coming up. So we knew that in advance, and that we'd have to get it through her mail order pharmacy. So on December 16th, we sent in the medication prescription by fax and electronically. Also, she was made to call. She had 2 hours on the phone during her workday that she was trying to get her medication and everything phoned in. And then she called my nurse on New Year's Eve, because the day after New Year's, she was supposed to start her radiation, and the drug still wasn't there. So my nurses and my staff spent hours on the phone with her mail order pharmacy trying to find out where her medicine was. They said they never got it, despite multiple phone calls, faxes, and electronic submissions. Sharon had to start her radiation late. She's delayed a week now in getting started on her radiation, and time is of the essence. This is a 52-year-old woman who should be cured, and time is of the essence. And then the last patient I wanted to share her story, I shared this spring at the committee meeting, and I wanted to give you an update. Nancy is a very special to me 57-year-old now woman with a history of breast cancer 7 years ago. And I shared with you this spring, if any of you were in that meeting, I know some of you were, that she thought she had shingles on her chest wall on her reconstructed breasts. And it ended up that when she came in to see me, I said, no, that's your breast cancer and it's back. By this point, it was across her chest wall and very painful. I told her there's this great new medicine. I'm really excited about it, and we can get this for you. And I have it here, and we're going to get you started on this, and it's 70% response rate. You're going to be doing better really quick. It took me 5.5 weeks to get that medication for her, even though it was sitting in my pharmacy. I had to go through a mail order pharmacy. that pharmacy moved it to another one, moved it to another one, and in this time period, her chest wall was rotting away, and she was having to take heavy narcotics to deal with the pain. I want to tell you today, her chest wall is clear. We've got her on that medication. You can't tell that she has breast cancer, and she's living an active and healthy life, dealing with the side effects of her medicine, but doing really well. But she told me last month, my pharmacy benefit manager says I have to use a different mail order pharmacy now, and I'm scared. She is terrified that she's going to have another 5 or 6 week break, and her breast cancer will come back, and she knows she's headed for a painful, painful journey again. And that's what I want to tell you today is that's not fair. That's not good health care. It breaks my heart every time I see a patient suffer. And my job is to get them through those days. But when I have these burdens in front of me and these barriers, it's really hard to carry on and do the best for my patients. So I want to applaud you for the work that's been done. I want to encourage you to not stop this fight. And it's in the best interest of Georgians. And I know your family members and friends have all been affected by this personally. It's a really personal, passionate plea I give to you to keep up the fight.
Thank you, Dr. Dillman. If you would please stay at the podium, we're going to allow our committee members, if they have any questions of you, if you do, just indicate that you would like to ask a question. Chairman Cooper.
Thank you, Doctor. Thank you very much for your service to our state, just in general, being an oncologist, and for coming to testify. I want to know if you have run into a problem that has come to my attention. Sometimes patients cannot afford their copay on expensive medicines like cancer drugs. Mm-hmm. And what I'm being told, although Sistine told me yesterday they're not doing this with their PBM, but what I'm being told is, used to, if the drug company wanted to pay their copay, say the cancer patient has a $3,000 copay, and the drug company says, we'll pay that in cash, not any kind of funny money or credits or anything, to the PBM, and you can make your copays and all and get your medicines. That the state of Virginia and a couple other states have had to pass a law because the PBMs are saying, no, the drug company can pay us, but we won't count it toward the patient's deductible.
That's correct. It's called a copay accumulator, and there's a lot of code names that CVS and Accredo and different places put on there that make it sound like it's some wonderful package in your insurance program, but it's called a copay accumulator, and then the patient still has to pay their $5,000 deductible even though that has been paid by the coupon. It's a travesty.
In other words, charity is not acceptable.
Correct. And the insurance company wins on that one again.
Okay, I think we may need to follow suit of
It's
Virginia
my
and
next
some other
battle.
states
That's
and
what that's
pass
my
a
next
bill.
battle. Yeah.
I mean, because since when this country of givers and people that care about other people, if I wanted to pay somebody's $3,000 copay so they could then afford their medicine, that I am told by a PBM that they won't count that toward their PBM, toward their copay.
It's correct.
Okay, thank you.
Are there any other questions from committee members? I have a couple. Are there any clinical advantages at all for patients receiving their medication through mail rather than from you directly?
No, and what we're seeing is, like I said, wrong doses being sent, sometimes the wrong drug. We have taken to putting no refills on our mail order because sometimes the pharmacy the PBM will go ahead and fill a drug that may not be the right thing, and then that patient has to pay the copay on it. And despite me putting 0 refills, my patients are being sent another fill on their prescription. So ASCO, which is a National Oncology Society, has put together with NCODA a list of standards about what makes a pharmacy good. How do you prove that what a pharmacy is doing is better? And that's really through one-on-one touch. But my patients are getting letters now from their mail order pharmacies saying, and it's being told by me to put into their chart, that that patient has a long drive to get to my office, therefore it's in their best interest that they get it through a mail order, which is not correct.
So are the drugs that are being mailed, are they typically drugs that you would have on hand at your clinic?
Yes.
All right. Any other questions from committee members? If not, thank you, Dr. Dillman, for being here.
You're welcome. Thank you.
Thank you for your comments. Our next presenter is Dr. Dean Sumner. He's with the Mercer School of Medicine and will share thoughts on the effects PBM practices have on overall healthcare system and the impact on rural providers.
So, Dr. Young, that was a moving presentation. Thank you for your service. And the only thing I can say to compete with that is I hit a deer 2 weeks ago. So, yeah, that's it. I'm Jean Sumner. I'm the dean at Mercer University School of Medicine, and I think most of you know that our mission is rural Georgia. We have an obligation, we believe, to bring information that affects that workforce in rural areas. And pharmacy benefit managers have been a negative influence on pharmacy and physicians, in a sense, in rural and underserved areas of the state. We spend a lot of time talking about teamwork, and that teamwork includes public health, the pharmacy, home health, PT, specialist, but the reign of pharmacy benefit managers has been unusually punitive for rural systems of care. All of you know we have a lack of physicians in rural Georgia. Rural Georgia has more than its share of chronic disease burden. We have an over-specialization of workforce in this state, and all states for that matter, and we have a maldistribution of physicians. So that makes rural Georgia much more prone to see the effects of a commercialization of pharmacy because it really hurts patients. And the previous speaker made that so clear. I spent my life in a small town taking care of patients in Wrightsville in Washington County. And you spend a lot of your time as a patient advocate trying to get medicines for them. And really beyond the pale, the inability to believe that what the pharmacist is telling you could have any sense. And he or she too is frustrated. This is a map of health literacy. You can see that rural and Georgia outside of the metropolitan area, red is bad. Health literacy has nothing to do with intelligence or education. It has to do with understanding the system. It has to do with using the system effectively. And when you discriminate against a health provider in those rural areas, it makes it even more difficult. So those people in those red counties need every health provider that we can provide them. The infrastructure is fragile, and every provider matters. I laugh at my friends in Atlanta sometimes because we hear about turf battles and people that don't like each other and groups that fight. We don't have that problem in rural Georgia. There's not enough of us. Every obstacle is magnified. So when you can't get that drug, and that pharmacist can't get that drug, and your patient can't advocate for themselves or have the ability, you're in that gap. And it takes away from your ability to take care of other patients. Cost is more of a factor. These people have insurance. Payer mix in most rural counties is not dissimilar anywhere you go across the state, but their annual income is less, so they don't have the ability to pay these exorbitant copays. And distance is always an issue. I've told you the story before of a few years back where my patients were told they had to get their flu shots at Target. I live in Wrightsville. I didn't even know where the nearest Target was. That is unfair. The same as the first speaker mentioned, patients who use CVS Caremark continually get letters that they must use a CVS. There's not a CVS in Johnson County, and depending on where you live, it may be 45 miles. That may be easy if you're young and employed and have a car that works, It's not easier if you're 85 or have children that live in Atlanta or no one to go for you, so there's non-compliance. I'm an advocate for independent pharmacy. Independent pharmacy, there are 350 to 400 independent pharmacists in rural Georgia. I think there's 695 in the state. And when you live in an urban area, you forget that independent pharmacy is disparingly more evident in rural areas. They are your partners. As a physician, you count on that pharmacist to help your patients get care. They are frontline health providers. They go back at night. They go back on Christmas afternoon. They go back in the middle of the night. They're patient advocates. They spend hours on the phone trying to find the right care. If you've been in a hospital lately, your discharge day, you're handed prescriptions, and you walk out the door, and you may have seen a different doctor every day, and you sure don't remember their name, and you walk in your pharmacy that you've used for 30 years, and the pharmacist says, none of these drugs are covered. Medication adherence is a major driver of rehospitalization, and the only person that stands between that patient getting that medication and not getting it is that independent pharmacist who picks up the phone, calls the hospital, harasses somebody to get the doctor on the phone and try to get a substitution. But what usually happens in rural Georgia is they call the local doctor. And then together with the local pharmacist, we figure out something that gets us through the weekend or gets us through the day until we can get this patient what they need. Rural pharmacist, independent pharmacy in rural Georgia, you can walk in and get your blood pressure checked. You can walk in and get a blood sugar check. You can walk in and say, I've got my medicines confused. What does this do and what is it? They help you understand how important it is to stay on your hypertension medicine when your blood pressure is controlled. They address that problem of health literacy. They are frontline health providers, and they are important, and they are under assault by pharmacy benefit managers. They have been for years. The total sales, and I don't know that this is the most important statistic, but they are $2.5 billion from independent pharmacies. You forget that when you're in a city and you see nothing but chain drugstores, but it's very important. The three largest pharmacy benefit managers are obviously CVS Health, Express Scripts, and Optum. CVS had the largest share. Together, these three corner 80% of the market. They have 180 million customers. They own 3 or 4 of the specialty pharmacies that the oncologist was referring to. And they have narrow networks so that you have to go to their pharmacy. And I agree with what the earlier speaker said. You're scared, and if you walk into an independent pharmacy or you talk to these independent guys, they're terrified of the pharmacy benefit managers because they are spending, and this sounds exorbitant, but it's a fact, $100,000 a week on inventory. If one of these guys takes them off their list of preferred pharmacies or doesn't let patients do them, they're out of business. I want to read a statement that comes from the Annals of Internal Medicine. And it's dated March 20th of 2018. The combination of increased size and scope expansion has prompted concerns that business practices of PBM are contributing to reduced access to prescribed medicines and lead to less adherence and worse health outcomes. That is the American College of Physicians, which I belong to. They are not a political organization. They are advocates for patients. It has gotten to where physicians have got to stand up to this business practice. I'll be glad to give you a copy of that article, which also enlightens you in other ways about the pharmacy benefit managers. It's very hard to find quality information about a pharmacy benefit manager. There was an article in the Journal of the American Medical Association in August of 18, called Medicare Spending on Brand Name Combination Drugs versus Their Generic Constituents. This is Medicare, I got that, but it's a pharmacy benefit manager, and it is looking at fixed dose combinations. It's drugs that have 2 drugs in them that can increase adherence, but they've gone out of their way to place these drugs on their formularies. If you look, the top line demonstrates the brand name combination drug spending for Medicare And it shows $3 billion. With the rebates, which are always told, well, they have rebates, and this brings the cost down. It's 17.5%, so it brings it down to about $2.5 billion. If the generic constituents of those drugs had been used, it would have brought it down to about $300 million. Now, I want to pick on one that I'll be clear. It's an outlier, some, but there are multiple examples like this. There is a drug that is on a lot of formularies in this state called Zegerid. You probably never heard of it. You can buy it over the counter at the drugstore. It's rather expensive too. But on formularies, if you use Zegerid, it is a combination of Prilosec or omeprazole and baking soda. Okay? You can go in a Dollar General. That's what we shop at in rural Georgia nowadays. But we go in Dollar General, you can buy Prilosec for nearly nothing. You can buy baking soda at the Piggly Wiggly in Wrightsville for 50 cents a box. I checked last week. The combination of those two drugs on a formulary for a PBM is $86.25 a pill. The cost of the generic components of that drug is 47 cents. We spent $28 million last year on Zegerid, a drug that is over the counter. And that's an outlier, but if Medicare had not allowed that drug and made them use generics, they would have saved $925 million. That's pine stumps. I'm told they're made, that makeup and gunpowder come from pine stumps. All I'm saying today is that we cannot afford health care anymore. We can't afford to waste the dollars we spend on health care. Those dollars need to go to patient care. I am so proud of our state legislature because of the transparency and the legislation that's been passed in this state, and an effort to think that our legislators are down at the patient care level trying to make this state a better place for Georgians. Rural Georgia is a very vulnerable place. I'm proud to be a Georgian with these people representing me and to the work you've done. But farmers and loggers and every other business in rural Georgia knows what they pay for components. They know what it costs when they sign a timber contract. They know how much it's going to cost them to harvest that timber. They're efficient and effective in their business practices. The transparency is we need transparency in PBM's practices. We need to not allow these exorbitant profits to be taken out of our state and not to be used for Georgians. So thank you very much for the work you do. I'm going to advocate one more time for my little book, The Price We Pay, Chapter 14. If you haven't read this book, read it. Chapter 14 is about pharmacy benefit managers. I mentioned it before when I was at the committee, but it talks about spread pricing that some of them have gotten away from, but they're very proficient at changing rebates to administrative fees, or the direct and indirect payments are called something else. They make it very hard to keep an independent practice, a pharmacy in practice in this state. Physicians in rural Georgia need their independent pharmacy colleagues, so I ask you to continue this good work that you're doing, and I appreciate your interest in the topic. Thank you.
Thank you for your comments. We have a few questions, I think. Representative Hawkins, would you please stay at the podium? Boris, Dr. Sumner.
Morning, how are you?
Okay. I have a question. I probably should have asked the oncologist this, but to your knowledge, the bill that we passed in 2014, 943, that says, and I quote, "The total amount paid by a covered person through all cost-sharing requirements to be no more than $200 per filled script for orally administered chemotherapy." Is that being adhered to? Do we know?
I can't. Where is she? Did she leave?
Okay. To your knowledge?
To my knowledge,
Yeah.
I really can't speak accurately on that, but I do know that you know the rules. I run into people in the grocery store who who just got bombarded with letters from these PBMs that completely contradict the legislation that went into effect.
233 last year.
Absolutely. So I don't know about that. I hope it there. But, you know, these large corporations are not afraid of those of us who don't hire a lot of lawyers.
Well, I think we can check into that too. Thank you.
Thank you.
Representative Davis.
I just wanted to make a statement that I just received an alert on my phone, and it was CVS Pharmacy low supply alert. And I think that's pretty ironic with what we're meeting we're having right now.
There's a recent article about shortages, and you know, I didn't bring it because I didn't know that it was relevant, but there's an article that came out recently about the shortages that happen. And all of us as a practitioner have experienced that. All of a sudden you're out of albuterol, or you're out of saline, if you remember a few years ago, or they're out of some drug that should not be short supplied. And it's gone for a few months, and when it comes back, the price is exorbitant. And not only that, the 3 manufacturers that had it before are now out of business, and there's 1 manufacturer. And I don't know enough about it to understand it, but I know it's not fair, and I know it interferes. Drugs like colchicine, which is a drug for gout, it's common. You know, I took care of a lot of guys down there that had severe gout, and people underestimate you can die from gout. Colchicine is not a daily drug, but it's an important drug in the regimen of gout. It was a drug that they used in ancient Rome. It comes from the crocus plant. It's dirt dog cheap until somebody got a hold of it. Now it was, the last time I checked, $6.60 a tablet. It ought to be essentially free. My husband, one morning on the way to church, and I'll be honest, I'm married. I wasn't married. I am still married to the independent pharmacist, though he's not in the business anymore. So we discuss price of drugs a lot, and that's why I stopped by on the way to church one morning to fill a prescription for a young Medicaid mother who needed a prescription for her child. And the drug was Zofran, and there was a generic. And the generic drug cost $8. And the brand name drug cost $1,300. And her insurance, her managed care insurance, required him to use the brand name drug. So I said, "What did you do?" He said, "I just gave her the medicine. Because if I ordered the $10,000 bottle of Zofran, it's just better for me to give that away." That is the business practices of some of these the corporate practice of medicine. And so we've got to keep thinking about those patients.
One more question. Representative Bentley.
Next. Is that good? Try next to it.
How about that? Okay. Thank you, Chairman. And again, thank you, Dr. Saunders, for your work in partnership with Mercer and Dr. Early down in Peach County. We're really excited about that partnership. But can you share or speak a little bit about, in rural Georgia, diabetes is really big. Can you speak a little on what you're finding in medications for diabetes, insulin versus the pills like metformin and things like that? Can you kind of just share a little on your findings in that area?
You know, metformin is one of the widest, if not the widest, prescribed drug in the world. It's old. It's been around a long time. It's expensive now. Insulin was created in the 40s. It shouldn't be thousands of dollars. Diabetics give up. Having a chronic disease is tough. And when you can't afford your medicine, or you're constantly being swapped from one medicine to the other, it affects outcomes. Diabetes also takes a team approach. And that independent pharmacy in rural areas is really important to help you make your glucometer work, or get you a cheap glucometer when you can't afford the strips, or give you strips. Diabetes is a huge problem. And yet the drugs of diabetes, which you can use, you know, when I first went into my practice, my father, who had practiced for a long time, said, I know you're just out of school, but old drugs work. I said, well, Daddy, I'm new. I ended up using a lot of those old drugs. They work. They're great. You can't use the old drugs now, because if you use those generics, you're asked as a physician often to do a prior approval on a generic drug, and but you don't have to do it on a brand name drug. And there's a limit to your time, and you can't keep doing that. So these patients are being forced to use more expensive drugs to change over the course of time. And you have to often adjust doses. I mean, a patient, if you're managing a diabetic, you may change the insulin 3 times a month or more often. So if I call you and say, I want you to go up and take 2 more units in the morning and another unit at lunch or whatever, when you go back to that drugstore early, you can't get that prescription filled because they say you're filling it early. It's too complicated. It's taken out of the physician's hand and the pharmacist's hand to somebody who does not know that patient or live with that patient. So you make do through practices that are probably not great. You know, you go to the sample closet and you try to keep them going or you swap them to something you can give them till you can straighten it out. But so much money is thrown away in health care that does not affect outcomes. So, you know, I'm held accountable. You know, and my hospital would keep up with every day, do I give them an aspirin when they have a heart attack? I have all that data. PBMs have not affected health status. They may say they do, but they actually interfere with access to drugs. I should be able to write for the cheapest, safest, most effective drug. I can't anymore. I have to write what's on your list. And what's on your list is the most profitable. It has the 47-cent generic that you're charging 80 cents, $86 a capsule for some of these oncology drugs. So diabetes is a huge area, and it's a cost driver too, not to mention lifespan and everything else, the complications. That's what I'm saying. The chronic disease burden of rural Georgia is much more ominous than any other part of our state, and yet these are the people that are most adversely affected in many ways by the regulations of the pharmacy benefit managers. The independent pharmacies are scared of them. The patients can't advocate. There's nobody to call. You don't know who to call. And so the doctor can help, but it's very frustrating. We want doctors, we want to build that team in those rural areas. We want to have clinics where you can go and get a prescription and go to your drugstore and get it filled and partner with a good hospital and support that. But it's really hard now. So,
Chairman Knight.
Dean, thank you for, and this is more of a comment and a thank you. First, I want to thank you for what you're doing with Mercer and your concentration on rural health care. It's so important. And I think when we also solve some of those issues, I think that's going to help all of Georgia. And some of those issues are not just rural. As your slide said, they're in some of our more urban and populated areas. But just to wrap up, and I think a comment you just made, you're the physician. You're the one that is licensed under the state of Georgia to provide health care. That pharmacist is licensed under the state of Georgia to provide health care. And that has been my beef, and I've said it many, many times before, is that the people who we license in Georgia to provide health care, starting with the physician at the top of the health care pyramid, okay, it is interference with what you do and what is in the best interest of the patient. And I appreciate what you're doing, and I appreciate how you're advocating for Georgia patients, and I look forward to working with you. Thank you so much.
Thank you for all you do.
Thank you, Dr. Sumner, for those comments. Our next presenter is Katie Groover, who is a cancer patient who will share her experience with forced mail order for her cancer treatment drugs. If you would, Katie, please come to the podium.
Hi. As mentioned, my name is Katie Groover, and I must tell you, coming into here, I was nervous. Now, my blood is boiling. I'm angry now. I'm so angry. I want to begin by expressing my appreciation in the opportunity to speak with you today, and to let you know how much I appreciate the opportunity for you to allow me to share some of my experiences in hopes that things can change, not just for me, but for others that face some of the same challenges that I face. A little bit about me. I've always been a healthy individual. I rarely got sick, never got the flu shot. Always had an annual physical, and in general, didn't take much medication, maybe a couple of pills here and there. However, on May 31st of 2011, that completely changed for me. My world was turned upside down when I was diagnosed in the emergency room with multiple myeloma. Multiple myeloma is a rare, aggressive blood cancer. In multiple myeloma, malignant plasma cells accumulate in the bone marrow, crowding out the normal plasma cells that help fight infection. There's no cure, but it's treatable, and it has seen significant advancement over the past decade. Prior to being diagnosed with cancer, I have held some type of job since I was 13 years old. The last 17 years of my career was spent in information technology. I worked with many clients in the US and internationally, configuring and implementing a proprietary financial software. I loved and embraced what I did. I had a great job. I was determined to continue to work while going through treatment. Working helped me take my focus off my cancer diagnosis. It was rough at the beginning, but I began to settle into a new norm of arriving at work much earlier than normal, just so that I could get in a full day's work. This gave me time to make the countless phone calls with my mail order pharmacy, trips to the local pharmacy, many visits to my doctor's office, and hours in the infusion center. It was a difficult balancing act between work and treatment. I continued to work for as long as I could, but eventually stopped working in June of 2014. This was due to the fatigue and the cognitive side effects that were being caused by the cancer medications I was taking. Not working was extremely difficult for me. I was an Energizer bunny, always on the go, rarely stopped to sit down and watch television or do anything. I was just always on the go. But after being on the cancer medications, I just could no longer keep up the pace. My first treatment, in which I received free medical trial medications that were hand-delivered to me in my physician's office, I achieved remission and continued with a maintenance medication for another 4 years, at which point I started to relapse. To make a long story short, this type of cancer is very aggressive. In layman's terms, the cancer eventually outsmarts the drugs, thus losing its effectiveness and allowing cancer cells to grow out of control. Treatment plans then have to be changed, requiring new medications, which means more red tape and dealing with the insurance because the new medications aren't on my formulary, more red tape with insurance, PBMs, affiliated pharmacies, and people that don't know anything about me. Which brings me to the point of why I wanted to speak with you today. Part of my current treatment requires that I take an oral medication called Pomalyst, which I started taking around March of 2018. Based on my insurance, my PBM mandates that I obtain this medication along with several other medications through them. The majority of the medications come from Express Scripts via mail order. Express Scripts considers Pomalyst to be a specialty drug, which they mandate that I get from a specialty pharmacy that they own called Accredo. To be very clear, I do not use Accredo because I choose Accredo. I use Accredo because I have to. We've all heard arguments that patients are forced to use PBM-owned pharmacies for specialty drugs so that they can get a higher level of care. Please allow me to dispel that myth. I don't get patient care from Accredo. I get a product shipped to me. In fact, it's almost impossible for me to speak with a pharmacist at Accredo. Instead, I spend my time being bounced around from department to department like a ping pong ball, talking with a dizzying array of customer service reps. I don't know these people. They don't know me. In fact, I don't think I've ever talked with the same person twice. I feel like a broken record every time I call. I always get transferred multiple times, causing me to repeat my information again and again. It's exhausting and so time-consuming. While my testimony today is focused on my specialty medication, it is important to point out that my care is also fragmented. When you take away patient choice, care becomes disjointed, where one pharmacy doesn't necessarily know what the other pharmacy has dispensed. I am forced to get some medications not directly from Accredo, but from Express Scripts via mail order, which takes about a week and a half to 2 weeks. I get other medications from community pharmacies of my insurance-approved choice. At one point, I was using 4 different pharmacies: Accredo, Express Scripts, Kroger, and Costco. I was using Costco because I could get some sleeping pills that I was taking for half the price, no insurance, half the price of what it would have been had I used my insurance. At one point, I feel like I need to keep a spreadsheet just to keep all my medicines in my pharmacy straight. If I were allowed to choose my own pharmacy and get everything filled at a local pharmacy that I know and trust, it would allow me to eliminate a lot of wasted time on the phone with multiple pharmacies, scheduling shipments, and talking with individuals who don't know me from Adam. Not to mention that all of my prescriptions would be being reviewed by the same pharmacy, making sure that they are okay to take with other prescriptions that I'm getting from my primary care physician and the other physicians that I see. I want to share with you, the last medication that I received was Pomalyst. I received it from Accredo on October 2nd of 2019. To my surprise, I did not receive my prescription for November. After weeks passing and several phone calls to Accredo, in which I was told the prescription was being processed, I decided to record my calls to ensure an accurate understanding of my conversation with the Express Scripts owned pharmacy. I want to share with you the details of the first call I recorded, which was on November 15th. After holding for several minutes and providing my personal information to an Accredo employee named Nikki, I was told my refill was received by the pharmacy on October 17th and that it was being processed. I asked her what the reason was for the delay, and she informed me she could not explain, that she was not authorized on my account. After holding for approximately 10 minutes, I was connected to a woman named Janine, to whom I re-provided my personal information. Janine informed me that I was provided with incorrect information and that Accredo had not received a refill request from my physician. I asked her why there was the confusion as to whether a refill had been received or not, and she indicated to me, she said, it's not the department this department does not complete refill requests. I asked her if I could be assigned a personal patient advocate, and she said, that is not how our system or our company works, and she offered her apologies. I asked her if I could have a direct number and she told me that there are several different call centers and that right now I was speaking to Florida. But the next time I call, I may be speaking to someone in Ohio, Indiana, Arizona, or maybe Tennessee. She acknowledged it was possible I may be speaking to someone different each and every time I call in. I then asked, in light of the delay, if I could fill the prescription at a retail pharmacy of my choice, and she indicated, no, this prescription is not one that can be filled at a retail pharmacy. Finally, I asked if Accredo could call me and tell me when they received the refill prescription from my physician. Her answer, there is no way we can notify you once we receive the prescription. The phone call lasted nearly a half hour and nothing was resolved. That was one phone call, but it is representative of what I go through month in and month out. Hours of phone calls with mail order service, then with the physician's office, speaking with 2 or 3 customer service representatives per phone call. They have the prescription, they don't have the prescription, they're in the process of filling it, they're not in the process of filling it. They're going to be shipping the prescription, but they can't tell me which time of day that the prescription will arrive, requiring me to stay at home all day because the prescription requires a signature. I have to call back, but I can't have a direct number. When Accredo or Express Scripts calls me and the phone numbers flash up on the phone, I don't know who they are because they're coming from different places and I don't have those numbers. If I could know the numbers, I could put them in my phone so when they flash, I could then answer the call. I discussed this with a higher up regarding the direct line and was told that it isn't possible due to their phone system and having multiple locations in multiple states. They are sorry they haven't processed the prescription, but I can't fill it anywhere else. Imagine working and having to spend this much time on the phone. What employer is going to put up with that? It's exhausting, and it is anything but patient care. I shouldn't have to be my own advocate month in, month out, fighting a pharmacy that is supposed to be providing me care. I'd like to think I'm of fairly sound mind, but what do people do who aren't of sound mind? It's crazy. Subsequent to the call I shared with you, there were approximately 3 other calls with Accredo. In 2 of those calls, they maintained they had yet to receive the refill request. It turns out they were wrong, and Accredo had received the prescription from my doctor's office sent on October 21st. They were refusing to refill it because they claimed I owed a copay. This surprised me. I was receiving copay assistance from a foundation. It turns out that the assistance from the copay had been exhausted, and rather than informing me of the fact and advising me of the copay, and rather than advising me of the other copay options, they simply sent October's prescription and billed me for it. They said, the sad thing is that despite my numerous phone calls, I first learned my order was being held, not by Accredo, but by my physician's office. After more than 3 weeks of delay, misinformation, and numerous phone calls, never once was I afforded the opportunity to speak with a pharmacist. Prior to the exhaustion of a copay assistance, Accredo had actually called my physician's office, informing them that I was not taking my medication. They were stating this because I declined a shipment. What they did not know is that I had spoken with my physician about cutting back on the dose due to some side effects of the Pomalyst. It seems when there is a foundation paying for the drug, they call and are so caring and empathetic. Determined that my course of treatment goes uninterrupted, but when the funds dry up or a copay is exhausted, the calls stop and the medication ceases to be delivered. I still haven't received my cancer medication, but that doesn't, I still haven't received my cancer medication from Accredo, but that doesn't seem to worry them too much. They know I'm out of money. I'm happy to say, though, that the drug manufacturer is currently providing me the drug, though I don't know for how long, and that came about because of my physician's office, not because of Accredo. November and December have been very trying months for me. My disease results in extreme fatigue and energy, and the energy I spend talking with individuals at 1-800 numbers over and over again, receiving conflicting messages, delays in receiving medication, and emotional stress have truly taken its toll. I'm not alone in my fight being forced to use their PBMs, insurers, and affiliated pharmacies. Through my years battling cancer, I have come across countless patients going through the same struggles, many whom have become friends. Like me, the struggles with insurance, the costly expense, and the emotional stress associated with fighting to get their life-saving medications needed to live takes its toll. Some have become so desperate, rather than navigate the 1-800 numbers, they have chosen to obtain drugs through international back channels, illicit online markets, homeopathic avenues, all due to high cost of the drugs they could not afford and to get access to drugs from their PBMs. And insurers and manufacturers have made this so difficult to attain. Sadly, some are no longer with us. So I ask you, what value do we put on the human life? What value? Wouldn't it be great if we had a chance to work with a pharmacy of our own choosing and not one that is being mandated by our PBMs? One that we could actually speak with the pharmacist face to face? One that would offer patient care regarding our meds, including over-the-counter and specialty meds? One that we trust and we feel safe and confident in? Think about it. One-stop shopping, with all my medications being managed in one system. I know this body has worked tirelessly on these issues, and I humbly ask that you keep up the fight. Patients like me and thousands of others are depending on it. Please don't tire. Please don't wane. As I and patients like me take solace in knowing that our General Assembly will stand and fight for us, no matter what the outcome. And I thank each and every one of you for letting me share my story with you today. Thank you.
All right. Thank you. If you would stay at the podium, are there any questions from members of the committee? Chairman Cooper.
I just want to say thank you. I saw your paper shaking during your whole presentation, and I know that to come before us, people think we're special. We're not. We're just like you, but we seem to sometimes intimidate people. And I want to thank you for coming and putting a very personal face on the problem that we're having and why so many of us are very concerned about this problem. I can tell you, and if there's anybody from Walmart here, they can tell you that yesterday for 2 hours I gave them a hard time by a new rule that they put in about medications, and I know that there are many of us in that room that are working on this issue, so I want to reassure you of that we're not going to let it go, that we are concerned, that we are going to continue to work for patients. And to thank you for the personal face you put on it. The other presentations talked about the problems, but they didn't bring up the fact, and I'm a nurse, when you are in the room and somebody is told that they have a very serious cancer problem, or any cancer almost for that reason, is extremely traumatizing, and the first thing they think is that they're going to die. And to have to use all the emotional and physical energy that you've had to use in trying to get your medications takes a toll on you and other patients' ability to concentrate on trying to fight the cancer and stay alive. And research is showing that that kind of stress does have a negative effect on many of the cancer outcomes. So thank you again for coming and presenting to us. Thank you.
Chairman Knight.
Katie, thank you for it's such an emotional and personal testimony. But one question, and it's a two-part question, but I want to clarify, has Accredo Pharmacy followed up with you personally at all regarding your course of treatment since your calls to them and trying to get your drugs filled?
You mean Accredo?
Yeah.
Do they call me?
Have they called you since this happened?
Only when, no. Since this has happened?
Yeah.
No, there's no money. They don't know that I've gotten it from the manufacturer. They don't know that, at least not from me.
Second thing is, and I want to make sure this is just clarification, but if I gather correctly, you don't have one pharmacist at Accredo that you can work directly with and who can answer a question, and I mean a pharmacist.
No, I think I've probably talked to the pharmacist since I started this drug back, I'm not exactly sure what month, but around March of 2018. I've probably talked to a pharmacist there maybe once. Typically speaking, it's always you speak to whoever, the call representative.
A service representative.
And they're not knowledgeable about,
They're not a pharmacist.
The people who answer the call,
Yeah.
they're pharmacists?
No, I said they're not
they're
a
not.
pharmacist.
Yeah, that's what I'm saying. They're not. And, and God love them because they're doing what they're told to do. It's much higher than where they are.
Well, I want to thank you for your testimony, and again, sharing what Chairman Cooper said. You brought the personal element to this so that we're seeing all sides of this issue, and I thank you for the courage that you've had to come and share your testimony.
Thank you for having me, and if there's anything that I can do to help you all fight the fight, I'm there. All you have to do is say a word, and I'm there. Thank you.
Thank you. Our next presenter is Jennifer Shannon. She is a pharmacist, and she will share examples of other PBM practices that serve as a barrier to care, including rebate-driven formulas and other patient mandates that are not based on clinical grounds, but rather on profits. Jennifer Shannon.
Thank you all so much for having me this morning. My name is Dr. Jennifer Shannon. I'm a clinical pharmacist, and I'm the owner of Lily's Pharmacy, which is located in Johns Creek, Georgia. I'm humbled and I'm encouraged to speak to you following Mrs. Groover's powerful, authentic, and courageous testimony. While her story is horrifying, it's not unique. I see this every single day in my own practice, and the harm this and other PBM practices cause is why I'm here today from my own community. The PBMs often tout that their pharmacists are trained for specialty drug management. However, I sometimes wonder if there's even a pharmacist in their building, because if you talk to any patient, they can attest, as Mrs. Groover did, that they never even get to speak to a pharmacist. Instead, speaking to customer service representatives time after time who are unqualified to make medical decisions. They make it nearly impossible for a local pharmacist to provide uninterrupted care. They are stripping patients of the opportunity to speak face-to-face with a healthcare provider and forcing patients who are fighting for their life to keep fighting to get their medications. The only thing special about specialty drugs is that they are expensive and that PBMs make more money for themselves, all the while causing harm and leaving patients to wonder if they will be able to get their medicine. And if this is how they have to live in order to live, is this the only way? The thing is, many of our own neighbors, own family members are forced into these very situations. The frightening part for me as a provider is that I continue to wonder, what will the PBMs deem next to be specialty drugs? Will it be insulin, a regular blood pressure treatment, something as simple as a life-saving diuretic for heart failure? They realize that patients are now conditioned to doing whatever their plans tell them, so the more we allow this to continue as is, the worse all of our health outcomes will be. And as bad as patient steering is, that's just one part of the PBM practices that hurt patient care. I manage a clinical transition of care program with Emory Hospital, where patients are discharged to us for various disease state management issues in order to allow us to help keep them out of the hospital. With what feels like every single patient discharge, once we try to process their prescriptions, we encounter roadblocks from their PBMs that hurt their outcomes and sometimes risk their lives. Last week, a 29-year-old male was discharged to me after being diagnosed with new onset heart failure following a massive myocardial infarction or heart attack. His PBM deemed that all meds not going through mail order would require a prior authorization, which is crazy. When we pleaded with the clerk on the phone, there was no healthcare provider, of course, to speak to. We explained he had had a massive heart attack, was currently in heart failure, and these medications were vital to keeping him alive. The only answer we continued to receive over and over again was, you'll have to submit a prior authorization. It could be 24 to 72 hours before it could be approved, and then we'll ship the medication. Well, obviously this isn't a viable option, and so fortunately for this particular patient, his local pharmacist provided him the medications at low cost for a cash price, because had he been reliant on that prior authorization or the mail, in that short week, he would have likely landed back in the hospital. In one short week, this young male I just described to you would have gone into hypertensive emergency, a heart failure exacerbation, and likely experienced another heart attack. This is just one example of PBMs continuing to compromise patient outcomes with their horrifying malpractices as a result of their profit-driven mandates. I would like to touch on a patient named Louise. She is 82 years old with a 70-year history of type 1 diabetes. Anyone that knows anything about type 1 diabetes knows that insulin is the only drug that can keep them alive. She is partially blind and lives alone. She was led to believe, like many others, that she had to use a PBM-owned mail-order pharmacy. This, of course, was before she met me. Her insulin, which is the only medication she requires, was held up in mail-order limbo. Day after day, someone would give her a different answer on what was going on with the medication. On the final call, she kept saying all she had left sitting in her dining room was expired insulin, and the non-healthcare provider on the phone proceeded to tell her, well, expired insulin is better than no insulin. I am absolutely horrified, but again, not surprised. We have let non-providers drive our care and our health outcomes. Are you comfortable with a call center representative making your healthcare recommendations? I, for one, lose sleep many nights over this very fact. Finally, I'd like to share the example of someone I'll call Mr. Smith, who was discharged from Emory Hospital to me on a Saturday for an acute gout exacerbation. It was his first exacerbation he'd ever had, and the medications being prescribed were new to him, and he had so many questions. To my surprise, the generic colchicine that I had on hand was not covered by his plan, as the PBM mandated brand Colchris to be dispensed, even though it was around $400 more expensive than the generic form of it that I had in my hand. How does this even make sense to anyone? The PBM, who is in place and touts that they're there to get patients the best contracted rate of medications, is mandating the more expensive medication. I, of course, got on the phone right away. I called the PBM and, of course, got a customer service representative who first recommended that I send him back to the ER that he just left 10 minutes before. Obviously, I'm not going to do that. He then said, well, can you find the brand medication? I called many pharmacies. No pharmacy carries the brand medication when there's a generic, cost-effective form available. After 45 minutes on the phone and escalating the matter to management, the prior authorization that I begged for them to do was finally approved, and I processed the prescription claim for the generic Colchris. To my surprise, once more, the plan was then penalizing the patient with a higher copay for the generic form of the drug than the copay would have been for the brand. Again, that generic form was $400 less than the brand name drug. He paid $20 more to get the generic. He recently had another exacerbation, and this time I sat down with him and made the recommendation to get him on a medication to control and prevent his gout, not just treat the acute situation. Please tell me if you can find one mail-order pharmacist that would sit down and talk to a patient to make sure this didn't happen to them again. I'm pretty positive no one in here can raise their hand. They don't care about patients, nor do they care about improving their disease states. This local pharmacist right here does, and I'm happy to say this change has kept him out of the hospital. I share this all with you because PBMs will use buzzwords of access, adherence, choice, improved outcomes. None of these are applicable or appropriate, and they're worsening our patient outcomes every single day by interfering with pharmacists like myself for the ability to provide real quality care uninterrupted. As a clinical pharmacist, our very own Grady Health System trained me to value the clinical evidence behind every therapeutic recommendation and decision. They use that old drugs work many times. I can say confidently that when a brand name drug is mandated, when there's a clinically therapeutic generic available, that is not a clinically based decision, it is a profit-based decision, driven by the highest backdoor rebates received. They have traded all of our health outcomes for market share increase with no second thought of the effect on a patient's disease state. Please help me and all of my fellow providers in Georgia by standing up to what has become so dangerous for all of the patients across our state and stop PBMs from having unlimited control on our health and harming our patients by preventing them access to good care with people who truly care. In closing, I cannot tell you how truly grateful I am for all of you that worked so hard to stand up for our patients last year, and how proud I am of the General Assembly for the work you did in 2019 to stop patient steering and allow for choice of good pharmacy care. But the PBMs continue attempts at steering, rebates driven by profits, and delays to life-saving medications, and they continue to destroy our health care and worsen disease states. I humbly ask you all again to continue this fight against the abusive practices, and thank you from the very bottom of my heart for standing up for the patients of our state and our community. I'm very grateful.
Thank you, Ms. Shannon. If you would stay at the microphone, are there any questions from members of our committee for Ms. Shannon?
Hey, thank you so much for being here. I want to touch on something you didn't talk about, but just maybe a year ago, I spoke to an independent pharmacist in my area, and DIR fees and what PBMs do to pharmacies, especially independent pharmacies, how they'll come back later and charge a fee, and maybe a medicine that you made 50 cents on, now you're losing money on, and the transparency in that. Can you touch on that just a touch about how the DIR fees affect you and pharmacists in general?
So the question regarding DIR fees and how it affects our practice, pharmacies are one of the few places that we get live adjudications of claims. So we know right then when we process a prescription, we will be reimbursed for the medication, whether it be 50 cents, minus $5 or positive $10. So it allows us to make an educated decision if we can manage to dispense this medication and keep our doors open, right? So DIR fees often, they come recurrently throughout the year. We never know how much that the PBMs are going to take back, and we don't really have a reason why, other than that they can. And basically, we'll dispense a drug and think we're getting paid 50 cents, and then a month later, we actually have to pay the PBM $200. So it's very difficult to run a practice, and I'm not the business person in my practice, my husband is, and maybe it's good for the practice of pharmacy because it's eye-opening to say, how can anyone run any business, let alone a healthcare practice, when you can't keep your doors open because you never know how much money will be taken from your account for no unknown reason. So,
Right,
yes.
yeah, you're flying blind.
It is flying blind, yes.
One other, do you understand about the scoring that PBMs score you as a pharmacist on and how that affects your DIR fees?
Yes,
And
yes.
so for things like statins or for medications that are monthly, how they score you based on how often your patients pick up their prescription, and when patients even pass away, later you'll find that you're still being scored because they didn't pick up their medication because they're no longer with us, or
Correct.
right, and so then your fees are affected by that.
Right, the scoring is a bit of a game, if you will. We have a 5-star rating, but our DIR fees continue to come and increase. So, I believe days covered doesn't equal patient adherence. So, viewing a drug being given to a patient is not the same to me as a patient actually being able to tolerate and adhere to it. So they're two different things, and that's why I go back to PBMs are not healthcare providers. They have all these scores and metrics in place to make sure people are getting flooded with drugs, but they never actually know if they're taking the drugs, and nor do they care.
And one last question, is that the reason that a lot of pharmacies go with the automatic refilling of prescriptions in order to meet their PBM and DIR fee requirements?
I can't speak for other pharmacies,
Okay.
and even myself, we don't autofill for that reason. We sync our patients to make sure that we keep their medications, together so that one pharmacist sees everything and can view the drug interactions and the safety of them. Nothing I do is because of a metric.
Yeah, I'm
Yeah, no, I
speaking more about the
understand.
big pharmacies, not
But
the
I
independents.
believe the corporate pharmacies do. They autofill, they flood patients with medications. That particular patient I talked about with the insulin, actually for the year prior, she had been sent probably 30 extra boxes of insulin that expired. And so she was flooded with drugs that she couldn't use because they were just coming at her so quickly. And that is not healthcare. Yeah.
Well, thank you very much.
Thank you for your questions.
Representative Cooper.
Okay, one of the problems that doctors are telling me that they run into from insurance companies is that they spend hours getting prior authorization. They do a procedure and then it's denied after they've had prior approval from the company. Do you find that in the pharmacy thing? Do you get prior approval for a drug and then have any of these people tell you that after you had the prior approval that they won't pay for it, won't pay?
Often, yes. Often monthly on many medications for people. It's a constant game. And I believe so often medications are held in limbo for that very reason. But yes, often the patient might even get a phone call saying, your plan, we've approved it as a plan, your pharmacy can process it. And then we try to process it and it says denied. And the worst thing about it is I'm always the messenger. They remain faceless as the pharmacists have to deal with it.
Is it denied before you fill it, or do you get denials after you filled medication?
No, we can't process it without an approval, so we'll know right away if it was denied. So,
Okay,
does
so-
that make sense?
Yes.
Yes, okay.
Are your examples of other similar practices isolated to just a few PBMs, or is this an across-the-board type of practice?
This is across the board, unfortunately, and I should have mentioned that even further. Every single PBM is doing the same thing, and it's a constant battle for patients, pharmacists, doctors. Just last week, I got a notice from a PBM that even though there was a generic cost-effective insulin available, we're not going to place that on our formulary. We still need to decide if it's going to be good. So the games are constant across the board, and it's exhausting.
I also heard that you mentioned House Bill 233, our anti-steering law that we passed last year, which took effect in January. Has this helped from what you've been able to see so far?
So HB 233, which again, I'm so grateful for all the work on it. You guys worked so hard last year. You know, it went into effect on January 1st, and although it's still early to tell, we have already seen the abuse happening and the blatant ignoring of the law. And the hardest part for me is, you know, all the work and blood, sweat, and tears that went into that legislation. And I find it to be such a slap in the face of the PBMs ignoring our state laws, their pharmacies ignoring our state laws, and that law is in place to regulate their pharmacies, and their pharmacies are basically saying, I don't really care what you do in Georgia, we're going to do what we want. But I own a pharmacy in Georgia, and I would never break the law. So I find that really difficult to understand how they just blatantly ignore what you all worked so hard for, what we all worked so hard for.
We have Chairman Hawkins, you have a question.
Years and years ago, we passed legislation that put the PBMs under the direct supervision and licensure of the Insurance Commissioner's Office. You as a pharmacist, would you feel comfortable in notifying that office that PBM is not adhering to the House Bill 233?
Oh, yes, I already have. So the one thing I'll say is it's up to us to report it, but so many pharmacists, and I think the Dean of Mercer said it best, we are afraid. We are afraid of the retribution. We're afraid of being kicked out of networks. It is frightening to stand up here and say what's happening to our patients every day, but we have to report it. But even last night, as I was leaving, someone walked in to get a medication. I went to process it, and it said mandated to mail order. And I called, and I said, hey, we have this law. It literally went into effect on January 1st. And the rep said, I know nothing about your law. This is what the screen's telling me. So this is where we're at, and the abuse continues, and that's why I'm so grateful. I can't say it enough, Representative Knight, for standing up for what is so bad right now in our healthcare system.
Well, we need to follow up with the Insurance Commissioner's Office, because if we pull their license, they can no longer operate in the state of Georgia. So they cannot negate our laws, and they cannot look around them. Thank you.
Thank you for that.
All right. Well, thank you very much for your comments. We appreciate your
Thank you so
presentation.
much, all of you again. Thank you.
Our next presenter is Dale Arrington. He's a patient who has used the same independent pharmacy for 56 years and is now being forced to use a CVS pharmacy. A complaint was filed with the Commissioner of Insurance, and they wanted to offer testimony.
Good morning. This is not my normal activity, so please bear with me. I'm Winnell Dale Arrington, and I live in Lithia Springs, Georgia. I'm a retired civil service employee with 33 years service and 29 of those with Federal Aviation Administration. My health insurance is Mail Handler's Benefit Plan, and I've had this insurance since 1993, 26 years. I am an associate member in the National Postal Mail Handlers Union. On October 28th, I received a letter from CVS Caremark stating important change coming to my prescription benefit plan starting January 1st, 2020. Medications are to be filled in 90-day supply at CVS pharmacy or CVS Caremark mail service. If filled anywhere else or in 30-day supply, they will no longer be covered, and I will pay 100% of the cost. Per this letter, I am to transfer my prescriptions using CVS website, select medications I take regularly, and they will transfer to the new pharmacy. The closest CVS pharmacy is 10 miles from my residence. This letter from CVS is why I'm here today. I have been with the same pharmacy, Wyatt's Pharmacy, in Lithia Springs since it opened in 1963, 56 years. I trust them with my care, and it is only 1 mile from my residence. The employees are concerned for all customers, and the service is first class. I was so upset after receiving the letter, I carried it to Dr. David Tucker, pharmacist owner of Wyatt's Pharmacy. He asked me, was I aware, of House Bill 233 to be effective January 1st. I contacted the Georgia Department of Insurance and completed a consumer complaint form on November 12th about having to change my pharmacy. On December 10th, I received a reply from CVS employee who claimed to be a member advocate who worked out of San Antonio, Texas. I called the state. I'm sorry, hold on just a minute. I called the out-of-state CVS employee, thanked him for his reply. He told me the mail handler's benefit plan is a fully funded plan. He explained that effective January 1st, the plan will participate in the Maintenance Choice Program. This program is a plan requirement that cannot be opted out of. Under terms of Maintenance Choice Program, plan members will be allowed 3 fills of up to 30 days supply of maintenance category medications at any in-network pharmacy. Once allowed fills have been exhausted, the option will be to either through the CVS Caremark Mail Service Pharmacy or fill a 90-day supply through CVS Pharmacy. I asked if he was aware of Georgia House Bill 233 for the state of Georgia, effective January 1st. He was not, and then found the House bill on the internet, and he said he would get back with me. My husband, Wayne Arrington, and I were married for 53 years. I lost him in March of 2017. Wayne is the founding chief of Douglas County Fire and EMS Department, beginning in 1974. He overcame many battles and hurdles during this time, and today the people of Douglas County are reaping the rewards. Wayne instilled in me the need to fight for whatever would be good, and that is why I'm here today. I don't know whether CVS pharmacies think they're entitled to ignore Georgia law somehow, but I am here to tell you that you all did. Passing House Bill 233 was a good thing, and I thank you for it. I also ask that you continue to fight for patient choice and access to care. As I said, for 56 years I've used the same community pharmacy, and now at the same time, your law takes effect. I'm being pried from my pharmacy and forced to either drive 10 miles or receive my medication through mail. I think my choice matters, even if CVS Pharmacy and my so-called CVS patient advocate do not. Maybe nothing will come from this for me, but hopefully it will be for others. And thank you all for your support.
Thank you, Ms. Arrington. One question. In all of the years that you've been using your independent pharmacy, have you ever been forced to go elsewhere before?
No, sir.
All right.
My husband and I helped stock Wyatt's Pharmacy. The first pharmacist or the owner was a friend of my husband's. So I have known every pharmacist that's ever been through that pharmacy.
Thank you. Thank you so much for your comments. Our next presenter is Nikki Bryant, a pharmacist. She will speak to the struggles of rural pharmacists and negative reimbursements in the Medicaid managed care. Nikki, please come to the podium.
On December 27th, we buried Senator Greg Kirk. I'm sure most of you knew him as a loving, passionate senator who always had a heart for doing right for his constituents and all people of Georgia. Some of you in this room know he was also my biggest fan and cheerleader. I adored him, and there's nothing we wouldn't have done for the other. You see, my grandfather raised us both, and we were both built with the same bricks by the same hands. He was my cousin and kindred spirit. So he might have gone to heaven, but he left me with a great responsibility and much work to be done. With his fire in me, I will continue this fight, advocating for those too weak to speak for themselves, voices so small in places where rich and important people want to forget. Those lives are who I represent today, and I will not settle for excuses and dismissals. I visited the Capitol several months ago and had an opportunity to share my story. I'm from Preston, Georgia, a tiny town of 400 people 8 miles west of Plains. My neighbors and my friends rely on me daily, and I'd like to share with you what that looks like. It's 11 p.m., and I get a call from a frantic mother informing me she is leaving the ER 30 miles away with her child who really needs medicine when they return home to Preston. I get out of my bed, I put on my clothes, and I head to the pharmacy. I'd submit the insurance claims only to discover I will be reimbursed $5 less than cost on multiple prescriptions from a managed care Medicaid plan. I come home every day and tell stories like this one to my husband. He always shares in my frustration and asks, "What's the point? Why and how do you keep doing it?" Because I love my patients. I celebrate when they marry. I'm there when they have children. I attend funerals when their family members pass away. I'm the first one that they call when their parents are diagnosed with cancer. Over the past 4 weeks, here are all the claims I have been reimbursed under cost. There are 15 pages. 90% of these claims are state-funded benefit plans. This is the thanks I get for caring for managed care patients while their profits grow into the billions. Contracts put into play by the Georgia Department of Community Health are granted to managed care organizations whose interests and revenues are not housed in this state and who take advantage of my kindness. Serving my pediatric populations continues in my pharmacy out of love for this vulnerable sector. Almost every prescription I fill for them is reimbursed by the PBM at below my cost. Would I ever decline to do so? No. Why? Because my heart will not allow me. They continue to make deals with companies who fight against me, who push members to chain pharmacies a minimum of 30 miles away for most of my patients. And who funds all of this? Me. My tax dollars fund my own business out of business. Let me say that again. Government contracts in this state funded by my tax dollars work to put me out of business. Since my last visit in September, I opened my second pharmacy location in Cuthbert, Georgia. The first independent pharmacy in Cuthbert in almost 15 years, and the first on their square in over 30. In the old days, there were 5 independent pharmacies there, but until recently, only one pharmacy remained, CVS. Between my 2 locations, I now serve 12 counties in Southwest Georgia, many in the top 10 poorest in the state. I'm no amateur to breathing life into independent pharmacies in rural desolation, and I'm certainly no stranger to how PBMs make it nearly impossible to survive. To apply to be a pharmacy who accepts CVS Caremark, the application fee is $1,200 and takes a minimum of 8 weeks, but potentially up to 12 weeks to process, in comparison to 2 weeks with most other PBMs, delaying competition in markets they already dominate with pharmacies they already own. When I visited before, the lobbyist for the insurance company said, "The one who holds the gold makes the rules." Truer words have never been spoken. I quickly learned after opening in Cuthbert, the city workers and employees of the Hospital Authority of Randolph County, Georgia, do not have a choice where to fill their prescriptions. They are forced to use CVS or mail order. The local CVS pharmacy in Cuthbert is so overwhelmed and understaffed, the patients wait 3 to 4 days for their prescriptions to be filled. The staff there have stopped answering the phone, and nurses get into their cars and drive to the pharmacy to provide prescriptions for their patients who have no other option. All I'm asking is to be compensated fairly and equally for my services and to be given an equal chance for business from government-sponsored prescription benefits. I'm a taxpayer in this state, and I should have an influence on how my tax dollars are used to support local economies. As it is now, I'm paying for contracts that are putting me out of business. With my cousin in my heart and the words of Joan of Arc in my mind, I am not afraid. I was born to do this.
Thank you for your comments. A couple of questions. Do your stores have a heavy Medicaid managed care patient makeup?
I do, yes, sir.
And being in this rural area, how do you reach all of your patients, particularly those that are immobile? Do you deliver?
Yes, sir. About 85% of my business in Preston is delivery. We're filling about 1,300 prescriptions a week, and there's only 400 patients in Preston, so you can only imagine. I have a 50-mile delivery radius, so we go into the most rural, desolate places in Southwest Georgia to provide care and services to those patients who would not have any otherwise.
All right. Chairman Knight, you have a question?
Nikki, I want to first say thank you. The spirit by which you continue this fight, especially in your area of Georgia, which I know one of our other chairmen have called a healthcare desert. You're a front line, and I think Dean Sumner mentioned it. A lot of times the pharmacists are the front line of healthcare. So thank you for what you're doing. Specifically, in your comments, would you go back to the part about the gold in your comments? I think you were quoting or were repeating what somebody had told you. Would you repeat that for me?
Yes, sir. The first time that I testified, the end of September, the insurance lobbyist spoke before me in a House subcommittee hearing on insurance. And that's what he said word for word. The person who holds the gold makes the rules. And in pharmacy, that's true, because if you are the richest company in this country, you can make the rules and everybody has to abide by them or they don't get to play.
Well, let me say something. Let me say something to you and to this committee and to everyone listening. This General Assembly in the state of Georgia holds the gold through our budget process. And it's a very large sum of money. So let me make it very clear. We hold the goal and we will make the rules. And that's a promise that I think I'm willing to make, and I hope a lot of my other colleagues are willing to make as we go into this session. Thank you for your courage and what you're doing, and I think it inspires us to work even harder on this issue as we go forward. Thank you.
Thank you, Ms. Bryan.
Thank you.
Our next presenter, Jocelyn Rodriguez. She is a patient who wishes to share challenges that her family has in connection with prescription drugs.
I'm Jocelyn Rodriguez. I live in Douglasville, and I'm here to share with you my experience as a patient, wife, and most importantly, as a mother, getting my family the critical medications they need when they need them. CVS Caremark, our pharmacy benefit manager, consistently makes using our rightful benefits very difficult by imposing mail order mandates, prior authorizations for the same drugs month after month, repeated delays, and making mistakes that put my family's health at risk. I often must pay out of pocket for medications that are necessary for the health and well-being of myself, my husband, and my children. In 2019, despite having insurance, my family spent $1,011.52 in cash so that we could have the drugs we need when we need them from the pharmacy we choose safely. Medications, such as a common seizure medication that I take for severe migraine headaches, commonly prescribed psychotropic medications that my son takes for depression and anxiety. These are medications in which accuracy, timeliness, and counseling are critical, and CVS Caremark has repeatedly denied my family our rightful benefits with their mandates. As a patient, wife, and especially a mother, I am unwilling to compromise to get my family the care they need, including paying out of pocket. How many other children's care is being compromised by these same mandates, prior authorizations, and delayed care? I've also battled with our PBM over my husband's treatment. He suffered a shoulder injury several years back and was prescribed opioids, which the PBM had no problem paying for. Now, as a result of the opioid use, he is prescribed medications for the treatment of opioid addiction, and the PBMs have put up roadblock after roadblock, delaying care and potentially compromising his recovery. It is distressing that they pay for the opioids that fueled his addiction, but not the doctor-prescribed medication to aid in his recovery. Before coming here today, I discussed with my family about sharing our private struggles with you, and they encouraged me to do so. That is because we are a normal, working-class family, and our struggles are like those of thousands of other Georgians. The issues related to our care are not unique to me, but are impacting your constituents and their families every day. I thank you for your time and sincerely hope that you can rein in these practices so mothers like me aren't faced with paying cash because their PBM compromises their family's care. Thank you.
Thank you, Ms. Rodriguez. Our next presenter is Ed Reynolds. Ed is a pharmacist and he is the mayor of Bainbridge, Georgia, and he's going to wrap us up touching on healthcare results of Medicaid managed care, low reimbursement in Medicaid managed care, and address claims that managed care saves money in prescription drug areas. Ed Reynolds, would you please come to the podium?
Good morning. Thank you, Mr. Chairman. Thank you to Representative Taylor and my Senator Burke. Thank you for joining us this morning. I appreciate the opportunity to be with you. I think we've seen a lot about perspective today, and I have a little bit of a unique perspective. So I wanted to share, I was asked to share that, and I thought it was important that I come share that. My unique perspective is I'm a second-generation pharmacy owner from Southwest Georgia. I'm down in that other area like Nikki that shows a lot of red on that map. My father bought the store in 1956, and we've been in the care of those citizens in Decatur County ever since. My father's brother was a pharmacist. His son was a pharmacist. His daughters are pharmacists. My son is a pharmacist, graduated last year from Mercer Pharmacy School. It's all we know how to do, you know. So, but I also served as the mayor of Bainbridge, Georgia. I'm in my 11th year as the mayor there, and my father also served as mayor of Bainbridge. We know about public service as well. So that perspective brought me to looking at the health plan for the city of Bainbridge and their employees. When we did the analysis of that, and I looked at the plans and what we were paying for prescriptions for our city employees, and then looked at see what I was being reimbursed, it made my head spin around. So at that point, I decided that I had to get involved in PBM information and do something about it. If my children were going to be able to be pharmacists in this state, I felt like it was important that I become involved in that. That led to the fact that we formed, some other independent pharmacists, myself, formed a truly transparent PBM. So we actually bill the city what the pharmacist rate is. It's a straight through transparent PBM with only a transaction fee. It's called ARC's Preferred Benefit. So that transparency led me to save over $55,000 in the first year for the city of Bainbridge. So that's somebody's job in the city of Bainbridge. That's another worker for our city, and it was over $12 a prescription just in the margin between what the pharmacy had been paid and what the city got a bill for. And we were a self-funded plan. Now, it was not, a fully funded plan. It was totally self-funded. So we were paying straight up for the bill for the pharmacy claims. So that led us into that, and we've been doing that now for the last 9 years. The company has grown, and we've picked up other clients, and we've been blessed with some other opportunities to pick up people who are looking to be in a transparent environment so that they have total access to their claims. They know exactly what they can pull up the website and see what they're paying for anything and anywhere. We have complete ability to go to any pharmacy of anybody's choosing. We even do specialty at retail. So it's a total patient choice and total transparent environment. But that's not why I'm here today. I'm here to talk about how some of these PBM practices have affected patients in my community. We've heard a lot today about many appalling cases of where care has been affected. And those include steerage, delay, clinical determinations driven by rebates. And you might think that's the current environment, that rising costs have pushed the legislature and others to these choices that had to be made to achieve budget forecasting. And it just truly, the reduction in patient choice and lesser care are just mandated by the rising costs. I'm here to tell you that I disagree. I disagree because of twofold reasons. One is because I've already shared with you that there are monies in the middle that should be going back to providers of care in these communities. But secondly, is because when you ignore these outcomes, you are pushing towards more medication errors, higher hospital readmission rates, more ER visits, and those things cost money long-term, as you well know. And it is no wonder that Georgia Medicaid's managed care programs are the worst scored in the nation on things like medication management for antidepressants, antipsychotics, and asthma, as well as statin adherence and controlling blood pressure. The bottom line is PBMs and Medicaid managed care aren't reducing drug costs, they're exploiting it for their gain. As Chairman Knight indicated, they are steering the most expensive drugs to their pharmacies, and then they are engaging in unimaginable markups which lead to record profits. They do this not only through steerage to their pharmacies, but also utilizing confusing drug methodologies and engaging in retroactive recruitments that warp the true cost of the prescription drugs. How is this still going on and are particularly confusing when we have public benchmarks that are transparent and are accurately reflect the cost of the prescription drug? NADAC is a drug benchmark that reflects actual acquisition costs. We don't need these games. I have seen the harm these practices have on my patients, and that I serve as a pharmacist. I've seen the financial harm these practices have on payers as a mayor, and I have seen how unnecessary these practices are as chairman of a truly transparent PBM. Most critically for Georgia, these practices on PBMs and managed care organizations in part causing the shutdown of pharmacies in rural Georgia. Pharmacies throughout our state are the first source of health information, as the dean explained, and many others. As Nikki referred to, we are the ones that most people call first when they have a health issue. So we're the ones on the front line. And so those primary health care sources are important to the citizens of our state. Managed health care organizations are underpaying claims in certain pharmacies, and in 2019, my primary store had over 6,000 claims that were underpaid under the cost of the drug. The total loss of these prescriptions for my pharmacy was $38,230. That is the loss of the cost of the drugs alone. That doesn't include additional losses for company faces from paying staff, bottles, labels, prescriptions delivery, all those other related services that we give as a pharmacy in a rural community. It's no wonder we are losing our independent pharmacies at an alarming rate. In Medicaid fee-for-service, while no one is getting rich, they pay for a transparent reimbursement amount and a fair dispensing fee. You should be finding ways to engage these highly skilled healthcare professionals that are residing all throughout the state of Georgia, but primarily in the rural portions to help take care of the primary healthcare needs of our patients, not put an additional burden on them. I completely understand the burden of leadership. I've always said city officials are the closest to the voters in the state. And many of those issues are brought to me every day in front of a pharmacy counter or in the grocery store. So I understand dealing with constituents. And many of these issues can be complex. I can tell you, and Dr. Burke will back me up, that, when we had to raise taxes in the city of Bainbridge to pay for things going on, I caught a lot of heat for that and probably still would. But it's sometimes hard decisions have to be made. But this does not mean we can avoid addressing them. And so I thank each of you for the time you put in up to this point on pharmacy issues and what you're willing to continue to do today. I ask you to help fight for patients in Georgia, the taxpayers, and rural pharmacies, and put an end to the status quo in Medicaid managed care and in the prescription drug games PBMs are playing by requiring transparent benchmarks, having true oversight, and carving prescription drug benefit out of managed Medicaid, and putting them back in a Medicaid fee-for-service. Thank you.
Thank you, Mr. Reynolds. You mentioned that you're on the board of a transparent PBM. Does that PBM own pharmacies, and does it steer patients to that pharmacies?
No, sir. And we actually have primarily required them to use, we try to let them use, we let them use anybody they choose. They have total patient choice, but we don't even promote mail order within our system at all.
All right. Are there any questions from the members? Chairman Taylor?
Mr. Chairman, thank you for being here today. This is great information that you've shared with us. I think all of our speakers have. But because you have your own PBM program, have you seen any trouble getting medications and certain items from the big pharmaceutical manufacturers?
We certainly have seen closed loops within certain manufacturers and what they're saying are specialty drugs, and we've been working with those manufacturers to try to bring access to those patients without using their affiliated pharmacies.
Does that happen because of your network or because you're a local pharmacy, or both affected by it?
Well, I think the manufacturers are using a closed system even within those relationships they have with specialty. You'll find that sometimes even certain specialty pharmacies can't fill certain drugs because they have direct relationships with manufacturers. So, what we do is we have clinical pharmacists on staff to try to work with doctors to direct towards outcomes and drugs that they will be provided, but in most cases, in the end, we may have to go through that specialty pharmacy if that patient's needing that drug.
Is that something we need to look at also? It concerns me because
It's a problem, you know, and it's a problem, and you know, well, it's not for the topic today, but it's a problem that they're limiting access through their own integrated delivery services through their own pharmacies.
just like we heard earlier that there were some problems getting medications, they're running out or whatever. I want to make sure that our local pharmacies are not hindered on top of that. So
Well, we certainly have a growing list of drugs that we cannot order because we are not allowed to through the manufacturer's specialty, and that's what was spoken to earlier. Their designation as specialty allows them to limit who they sell to, and then control the cost or profits in that case in that way.
Thank you again. I appreciate
Sure,
it.
thank you.
Chairman Cooper.
Thank you very much for your presentation. And I have a question, and maybe I'm just not getting it, but so you can help me understand. My dog was sick recently, and first let me say we tell patients to shop pharmacies because I know that there is a difference in what pharmacies often charge. But it was really brought home to me because I went on the way home from the vet. I stopped at CVS, and I asked about the medicine. It was $406. And I went, thank you, I'll pass. And the vet had given me some medicines. I mean, I paid for them. And shopping around, I got the prescription filled for $48 at Costco's. How are these differences? Do the PBMs charge, is it because they own, like CVS owns its own PBM, so they're not charged? And do they charge certain pharmacies different amounts of money? Where's this coming from? How can there be that much of a discrepancy? Who makes the money on that?
Well, I didn't mean to interrupt. It was a cash prescription in that case, right? Or is this okay,
cash.
so this was not covered by a plan because it was for your dog, right?
No.
That's what I'm making sure I understand. Well, in a cash situation, it's like other situations where the pharmacy can set their own cash profit and margins. So if there is strictly on cash, now I will say that there is a usual and customary that is applied to many cases for insurance, and so in the case of certain chains or they have to set their cash price very high because they're trying to show their usual and customary being very high, so that when they bill insurance for that same drug, then they don't run into a problem of showing that that's not what they would have charged if you came in there for cash.
Okay, but we tell patients to go. I know I've told patients to shop because I've seen the differences on patients who would be using insurance. And where at one place it might be $167, but it might be $30 at another, or $50 at another pharmacy.
Well, if it's on their plan, then sometimes we can be cut out of preferred networks. For instance, we were talking this morning about certain chains that will not allow them to fill at my store at all. But there are still some plans and PBMs that say, well, we're going to pay these sources better and have a lower copayment than at others. So they also have preferred pharmacies within networks as well.
So the PBMs can make that decision?
Oh, yes.
Okay, and so they can pick and choose who they want to give a good deal to, and...
Right. And there's preferred networks, which is so that patients get driven. That's another way of steering, obviously, but yeah.
Okay, got it. Thank you.
Mm-hmm.
Chairman Knight.
Thank you. Ed, thank you for your testimony, and I appreciate you coming up from Southwest Georgia. One, thank you for trying to be, with this transparent PBM, thank you for doing something that, quite frankly, I think we need to do, not only in this state, but across this country. But there were two things in your comment. I want to get some clarification, if I will. Both you and Nikki Pryor, and I've heard this from other pharmacists, are regularly, and you're holding up the actual printouts where managed Medicaid is actually reimbursing you less than the cost of the drug. And if you don't mind, just quickly repeat those numbers and for what you've told
Well,
us.
for me in 2019, it was over 6,000 prescriptions. Now, in my primary store, it's a very busy store. So I mean,
just in managed care.
And they were just in managed care.
Yeah.
So $38,000.
So when we look at this, and again, this is more of a statement, but this is becoming a theme. We're sitting here with the state is contracting with a third party. That third party is then dictating the contracts by which, in essence, these Wall Street companies are basically living off the backs of the independent pharmacists, and I dare say it's probably going on in other fields of healthcare, whereby they're profiting and actually at the expense of the healthcare provider, whether it be the pharmacist, whether it be the physician, or others, because I've had other issues within, physician issues. So that's becoming clear. The second thing, and a follow-up to Chairman Taylor and her comment about specialty drugs, over the interim, I've had some conversation with the manufacturers, and I asked the exact same question regarding specialty drugs. Why are there exclusive contracts with specialty pharmacies? That's not choice. And I'm still yet to get an answer. So we're working on that.
Well, and I appreciate it. And if I have a moment of follow-up on that as well, I have no proof of any of that, but I suspect in those same prescriptions in my community that they're not underpaying CVS for those prescriptions. So I don't have any proof of that, but my suspicion is that. And I do know that many of my colleagues are being underpaid and then literally every month receiving, including myself, a letter from CVS to buy my prescriptions in my business. So if they know by being the manager of those claims, if they know they're underpaying them, why would they want to buy my business? Thank you.
Thank you for your comments. This is our last presenter. I wanted to thank each of you for being here today. Thank you for your attention, members of the committee, the presenters. Been a very informative session. Thank you, and have a great rest of your day.